The woman you're about to meet struggled with terrible discomfort and pain that radiated throughout her body. It would turn out she had a condition often overlooked, misdiagnosed, and dismissed.
I was not willing to accept that a full hysterectomy was my only solution.
How she finally found a doctor who could diagnose it and treat it right here at the University of Kansas Health System. Good morning, I'm Alexis Del Cid. Welcome back to All Things Heart. Chronic pain can affect every aspect of your life, including emotionally, physically, and for so many women with a particular syndrome, their pain goes undiagnosed, misdiagnosed, or dismissed entirely. It's called pelvic congestion syndrome. It's kind of like having varicose veins in your pelvis. And Sherry Noller told multiple doctors her problems, only to be told that it wasn't really happening. But she finally found answers and relief right here at the health system.
Right by that freckle.
This small reddish mark on the right side of her neck is the only visible reminder of what Sherry Noller endured.
Today I'm feeling great. I'm feeling wonderful without pain.
The Joplin woman's journey began in June of 2021.
I felt as though I had a constant icy hot feeling inside my body. It was a pain that would radiate down through my left leg down to about my knee, and at the worst of it would also be radiating up my left side into my rib cage.
Even more maddening, it was a pain deep inside her. Sherry couldn't find it, couldn't relieve it with any kind of pressure.
I was also feeling like my hips were just kind of out of joint a little bit. I was trying to stretch, I was trying to move around to get some relief, and nothing would help.
Over several months, she saw multiple doctors and had multiple scans and tests, everything coming up clean, indicating she was perfectly healthy.
It impacted my mental health for sure.
At 38, Sherry felt despair. Then she started doing her own internet searches and she came across something intriguing. Dozens of Facebook pages and groups dedicated to something she'd never heard of, pelvic congestion syndrome. In the simplest terms, varicose veins in the pelvis.
What I found was a community of tens of thousands of women.
She asked her gynecologist in Joplin about it and says she was stunned when the doctor told Sherry that she didn't believe in pelvic congestion syndrome. Even worse,
the only way to remedy pelvic congestion syndrome was to have a full hysterectomy.
Sherry took the reins, reaching out to a doctor at the University of Kansas Health System that she'd read about through her various searches, vascular and interventional radiologist Dr. Adam Alley. Dr. Alley took one look at her CAT scan and validated everything. Sherry did have pelvic congestion syndrome, and even better, Dr. Alley could treat it.
We are so happy to have Sherry join us virtually this morning. Thank you for being here, Sherry. And here in the studio, we have two doctors who treat pelvic congestion syndrome. We have Sherry's doctor, vascular interventional radiologist, Dr. Adam Alley. Thank you for being here. And we also have vascular surgeon, Dr. Axel Thors. And Sherry, the reason you talked about your neck at the beginning being the only thing is because they go through your neck to reach your pelvis. We're going to get to that in a minute, but first, it's been 2 years since you last joined our program. How are you feeling physically today?
Physically, I am feeling great. The pain that I once had has not returned, and I've been able to move on with my life. It's been wonderful.
Boy, that's what we like to hear. Dr. Alley, what causes pelvic congestion syndrome, and more importantly, why is it so difficult to diagnose? Sherry went through the ringer.
Oh, those are two great questions. So what causes pelvic congestion syndrome is a dilation of the veins. So the best way to think about it, and the way I describe it, is you can think of your vein like a water balloon. So if the blood's not moving the way it's supposed to, as it collects in the vein, it'll expand like that water balloon. The walls will get stretched, they can get inflamed, they can hurt. Eventually they'll start remodeling and taking that snake-like appearance, and that's what varicose veins are. So within your pelvis, when you have that situation and those pelvic veins get engorged, that is pelvic congestion syndrome. And so that's what causes it. The reason that, in my opinion, that it's been underdiagnosed in the past and the present is because it was originally a diagnosis of exclusion. So what that means is there are lots of different reasons you can have pain in your pelvis. And so they would go through a large workup and diagnosis to make sure it's not anything else. And so when they did that, finally arriving at pelvic congestion syndrome, sometimes it gets passed over. Additionally, if you take CAT scans of, let's say, 1,000 women who've had children, some of them may have dilated veins, but they may be asymptomatic. In those particular patients, if they have the dilated veins but don't have the pain, in that situation, then you wouldn't treat them, you would just follow them. And so those reasons combined are why it can be very underdiagnosed. But there's a lot of people out there who have this. It is treatable. We're happy to treat it, and the results are pretty dramatic. So,
Dr. Thors, I want to touch on the heart connection because this is all things heart. So the question is, what is the risk to your heart anytime you have enlarged veins anywhere in your body?
Well, I wouldn't look at it in those terms in regards to the heart itself. The veins are, if you want to simplify things, the storage tank of blood for your body. So the veins are different than the arteries. The arteries pump at very high pressure. The veins, however, pump at very low pressure. So they rely on little one-way valves inside the veins to move the blood forward, and in this case, move it against gravity back to the heart. In order to do that, these little one-way valves have to work. And when you start seeing pathology, whether it's pelvic congestion syndrome or varicose veins, it's when those valves have failed. And blood is primarily water, so it's very heavy. So when it pools, because of those valves are failing, then these veins can get big and dilated, like Dr. Alley was saying, and become balloon-like and start to cause inflammation, and that's what leads to the pain.
When Sherry talked about being, basically, Sherry, you were told you needed a hysterectomy to relieve your pain. Did they give you a diagnosis?
No, they did not give me a diagnosis. I was told that a full hysterectomy was the treatment, or if I so chose, I could have exploratory surgery to try and find the problem, which to me at the time just seemed it was really tough to swallow. At the time I was done having kids, but at the same point in time, I knew of and had researched the implications of a hysterectomy at 38, and I wasn't prepared to go through that yet. And so I felt as though with what I was going through, there had to be other answers.
Dr. Thors, what are your patients typically misdiagnosed with or told before they finally reach you?
Well, as Dr. Alley mentioned, it's the many different things that can happen, in this case in a female body, whether it's endometriosis, other pelvic disorders. As he said, it is a diagnosis of exclusion in many times. They're looking for solutions under multiple stones, but not finding the solution because it's none of those things. And the impetus for us as experts in this field is to get this message out, which is exactly what we're doing this morning, to help people understand this condition and why it's so common. Any woman that has had more than one pregnancy is predisposed to this condition because pregnancy can lead to engorgement of the uterus, engorgement of all the veins that lead out of the uterus, and that can lead to this pathology. It's completely benign pathology, but it can over time lead to these debilitating symptoms.
Can you get pelvic congestion syndrome if you haven't given birth?
I have not seen that personally.
Have you, Dr. Alley?
Yes. So the short answer is there's something called the way that we've advanced the understanding of this disease. It is now part of something called pelvic venous disease. So classically the ones, as Dr. Thors was saying, are in women who've had children. But you can have iliac vein compression or renal vein compression that can lead to engorgement of the pelvic veins. So in other words, if I have a garden hose and I pinch it, behind it, it'll blow up like that water balloon phenomenon we were talking about. The blood's got to find another way to get back to the heart and the lungs. So what it'll do is it'll work its way through the pelvis. And what happens then is that the veins will dilate and you end up with the same thing. And so when the valves aren't working, as we were talking about before, is very common in pregnancy, there is additional situations where you can get engorgement of the veins. The good news is that Dr. Thors and I treat all of those. So there are solutions for it. So while it's most common in women who've had children, it can happen in other situations as well. One of the things that we're excited about is, so about 7 years ago, there was a large paper about pelvic venous disease, consensus among societies from doctors and scientists who study this, and there was the SVP classification. The SVP classification system is a descriptive system to describe all of those pelvic venous phenomenon in one paper. What we've done at KU is, while it provided a good descriptive thing, what we were looking for is evaluative instruments also. And our commitment here to advancing the field of medicine, we needed something that followed the chronic pain with that system that's durable over the long periods of time. So we were excited to complete that prospective study of our own pain scale last year, and we presented the results at the Society of Interventional Radiology last spring, and we're currently working on publication, and Dr. Thors and I collaborated on that, and hopefully that'll be published soon. So.
We're going to get to the paper in just a little bit after we show you some images from Sherry's case that Dr. Alley, I believe you provided these to us from when you were treating her. What are we looking at in this X-ray here?
So what you're looking at is those are coils in the left gonadal vein. And so what coils are, they literally, if you just put it on a table, look like a slinky. But they pack the vein. You can think of it like putting cement in a garden hose. And so what happens is you actually, that vein will thrombose. It won't fill up with blood anymore. So think about that water balloon again. If we can compress it and fill it with concrete, it won't fill up and it can relieve the pain.
So are the coils still in Sherry's vein then?
The coils are a permanent implant. They stay in there forever. They scar in. And they're safe. So.
And you reached her pelvic area through her jugular, which is a long journey, and I wouldn't think to reaching the pelvis through your neck.
Yeah, that's a great question. So it's all connected. There are two different access points that are common for this. You can come in through the neck or through the hip from the common femoral vein. From a technique standpoint, in her particular case, I prefer the neck because the angle into the vein coming from the belly is just easier to get down there technically for, to make sure our instruments don't come out of the vein. And so that's the reason that we chose that. But yeah, it's pretty cool.
Dr. Thors, do you always go through the neck too?
I actually take the opposite approach. I come from the femoral vein, but I use a device called a steerable sheath. Like Dr. Alley said, it is a difficult angle. And many times you don't want your instruments to come out of the space you're trying to work in. Right. But we have some technology that can help us mitigate that concern.
We have images as well from one of the patients that you have treated, that you shared with us, and she gave us consent to share these images. What are we looking at there? What part of the body is that happening in?
So here we're coming up from the right groin area, and you can see me taking a picture of what's called the left renal vein, which is where this gonadal vein that Dr. Alley was referring to originates from, where actually it's trying to drain to. But in this case, in a normal anatomy, when we take pictures from that location, we shouldn't see anything on the left side of the screen there. But as we can see in this case, we're seeing that contrast material just falling into the pelvis, and that's by definition reflux within that vein.
Okay.
And here I've already started to load this area. Actually, this was a second time. You can already see some coils in this location from an initial procedure. And this is the second time we intervened as Dr. Alley mentioned, you can close off certain areas, and then, you know, the body will find other routes to reroute this blood, and that's what occurred in this case.
So the coils, just so I'm understanding from a non-medical perspective, you put coils in the offending vein, the one that's all puffed out, overfilled. Where do the coils, how does it work again? Can you explain how the coils are working?
So the coil,
to stop it?
So the coils are, they're made out of a material that when you package it, it actually stays straight. But when you put it inside of the body and it heats up, the coil itself will take a different shape, so it'll coil. So if you think of a slinky, and what happens is you can actually design those so that they're different sizes, so that you can tailor it to different sizes of the vein. So if you think of the diameter of the circle of the coil, you can utilize that to your advantage, and you can actually pack that in the vein, like, as we were talking about before, like cement in a garden hose. So the idea is that you don't want that vein to fill up with blood anymore. Now the good news is the vein isn't really working anyway, so your pelvis will drain through other veins, and it's just collecting in that vein. And so that is how the coil works, and the whole idea is to pack it and get it to not fill with blood anymore.
Dr. Thors, is this an ovarian vein embolization? Is that what he's describing, or is what
gonadal
you do?
vein, ovarian vein is the same thing.
And we do have, I believe, another image of the ovarian vein embolization, which you can see on the left-hand side of your screen. What is that part?
Yeah, so same picture we can see coming up from the right groin area. This is the device called a sheath that is parked in the left renal vein, which is the main vein that drains the kidney, which you cannot see in this frame. And then this giant vein that you can see is almost the size of the kidney vein is her gonadal vein. And so this patient had profound symptoms.
It's not supposed to be that big.
No, this blood should be going up.
Okay.
All of that blood was going down into her pelvis, and she was miserable.
Yeah, I can imagine. Sherry, I want to ask you, I can't get over the fact that you're doing all this research because you're so desperate, only to be told by a different doctor somewhere else that it doesn't exist. That must have been gut-wrenching.
Yep. It was, especially when through my research and through these groups where I was kind of watching what was going on and learning from others that had similar types of pain that they were experiencing, and working to do some searches to. Really what I was doing is I was starting to gather language that I thought would be helpful, because I didn't know what to look for and I didn't know what I was asking about. And so I felt that the thing that I could do best was just learn more from these other women of what they were going through and the language they were using. And so that started helping me when I was trying to look for other medical systems that might have something or may have answers or papers, as Dr. Alley had mentioned. And in working through it, I went beyond what my symptoms were, and I started implementing other words and, started learning that this could be a vein issue. And so I was utilizing things like, vein pain in my pelvis and different things like that. And although I had been told by a doctor that they didn't believe that pelvic congestion syndrome was a legitimate diagnosis, leaving that appointment, I had already identified Dr. Alley and his office for the work that they do there. And so I knew at that point in time that my next step was to reach out to his office and to see if he could help me. And that's exactly what I did. And, I went from a perspective of I need to learn, I need to advocate for myself. And I was very much so disappointed in hearing from a doctor down here that they didn't believe it was a legitimate diagnosis. However, that helped me feel emboldened to learn more and to ask more questions. And that's what I did, is I asked a lot of questions. And when I did get the call and have the appointment with Dr. Alley, and he said, Yes, it didn't take him long. He said he looked at my scans and it was easy to tell, and it was a big sigh of relief.
Thank goodness. You're the perfect example of, one, advocating for yourself in your healthcare, and two, getting a second opinion. Because in this case, you found this team here who's spectacular, and you didn't get a hysterectomy, which you wouldn't have needed. We already have some great questions and comments coming in. If you have a question or a comment that you'd like us to read out loud on the program, you can send it to us on YouTube, Facebook, or the All Things Heart email. You will find all the links right here on your screen, how you can connect with us in real time. And doctors, you are both so passionate about treating women for this and doing the right thing. There's a paper that Dr. Alley was talking about that you wrote, published recently. What is the main focus of the paper? Dr. Thorus, take it.
Yeah, the main purpose of the paper, number one, is awareness. Number two is to outline treatment algorithms and modalities. And number three, to determine a pain scale, something objective that we can measure after treatment to many of the women and patients in general that get this treatment will see relief, but we need to be able to quantify that in some way. So I don't know, Dr. Alley, if you agree with that.
Yeah, absolutely. That's the purpose. So traditionally, they'll use a visual analog scale, which is not just used in medicine, but it's those smiley faces. And
we have a picture of those too.
Yeah,
we'll show our audience.
You can have a smiley face because you had a great day that is not related to your pain. And so it's important to have something that is an evaluative tool specifically for this. There were some that existed before, but the difference with ours is it follows them out to 1 year. So it's long-term, durable information that this works. And the thing I'd like to reiterate is that we're not done. So our commitment here at KU, we have a multidisciplinary practice, which is essential to driving things forward, working together. We've recently been accepted on a nationwide multi-institutional study for pelvic congestion syndrome. We are gearing up for that now. It is exciting. It's led by some very excellent physicians from the East Coast, and we're excited to be a part of it. So. Yeah, the research continues, the drive continues, and getting the message out there that this can be treated is very, very important.
We have the leaders here at the health system who are leading that charge. We also, Sherry, at your worst, I just want to ask, or no, let's ask this, average day, would you have been the most frowny face on there? I mean, were you just walking around in a constant state of discomfort?
At my kind of average pain, I was at a usually a 7 on a good day, or maybe good time of day. I would be down to a 5 or 6. I learned that when I would get up, from sleeping, I would feel a little bit better. But once I started my day, I mean, it was a pretty common 7, just kind of working and doing my daily life. And then it would typically only go up from there when I was in the midst of my day, spending time with my family, working and things.
Yeah, that's no way to live. No one deserves to be at a constant 7 or anything other than, you should be at 0 pain throughout your day. I want to get to some of our questions and our comments that are coming in from our viewers right now. Ruth Ellen wants to know, why would a previous doctor dismiss this condition? Is that concerning? And I would also add to that, like, are you able to educate other doctors so no one's telling people like Sherry that it doesn't exist? Dr. Thor or Dr. Alley?
Yeah, so it's constant. So you have to keep educating. So education is paramount in doing this and continuing to get more data. So the more studies we do, the more data that's there. No one's going to know about it if we don't get out there and talk about it. And so part of what we're doing today, and part of our effort as part of our practice, is to get that message out there. Mm-hmm. And so that is part of our mission here, is to continue to address this issue and make sure that we are, getting it out to the community and people know about it. and working that way.
And Sherry, part of what the doctors are talking about, you're also a huge part of by sharing your journey. And I hope you can, we're going to send you a link of this program. I hope you can share it on all those Facebook pages, because all the women who are sharing their journeys are who helped you find Dr. Allie and are helping other women find Dr. Thors. So that is really important, and you're a huge part of that. Jeremy wants to know, there are so many veins all over the place in the body. Do you often see that there are other vein issues that seem to pair with this condition? Dr. Thors.
Yeah, actually, this is very well published. I published a paper on this. The association between varicose veins, for example, and pelvic congestion syndrome is actually high. Now, we don't know, as Dr. Allie said, we're still figuring out what that association is. So you can't just draw a line straight between the two conditions. But short answer, yes, we think so, but we still have some more work to do to prove that.
Jeremy has a follow-up question, Sherry, for you. Jeremy wants to know, did it hurt more when you were doing certain things? Like, was it worse when you were standing or sitting or walking?
So I expected there to be a difference, but really the pain would be there. I have a pretty sedentary job for work. I sit at a computer a lot, but then I have boys that were always busy with sports and things. And I couldn't really pinpoint a time of day or a certain activity that inflamed the pain or made it worse. It was just kind of this radiating pain that would come and go. Like I said, unless I was laying flat, getting up from bed or something, I didn't get any relief.
Oh my gosh. Marge has an interesting question for the doctors. Marge wants to know, she writes, men have a pelvis. Can they get this too? Dr. Thors?
Good question. Short answer, yes. As Dr. Allie mentioned, there are multiple conditions that can create backflow, so to speak, into the gonadal vein, into the pelvic veins. And you know, you have multiple collaterals, multiple channels where the blood flow can go. Short answer is yes. I would say more commonly we see this in women, as per our conversation today, but can it happen? Absolutely. Have I treated it? Yes.
You've treated it in men?
Yes.
And is it as severe as with Sherry describes?
Absolutely, it can be.
Wow. Anne wants to know, and I'll send this to you, Dr. Allie, I think you touched on this a little bit, who is mainly at risk and at what age does this typically develop?
So as we mentioned before, this is most commonly seen in middle-aged women who have had children. That's by far and away the most common patient population that we'll see. There are, again, other conditions that can lead to engorgement of your pelvic veins. So if you have chronic pelvic pain that seems unexplained, it is worth looking for a vascular cause. Mm-hmm. But yeah, typically it's women who've had children.
For some final thoughts on this topic and today's takeaways, Sherry, I want to start with you. What do you most want people watching to know?
What I would like for people to know is that they're not alone, that if they're feeling something, if they're unsure, to definitely be following up with their doctors, but also be your greatest advocate. And the way that I found to do that was through asking questions and also, being very careful, but trying to find some answers online. And I didn't go into that lightly. I was trying to be very cautious and careful about the types of searches and who I was reaching out to regarding the questions that I had. But one thing that I learned the most is that we need to advocate for ourselves and learn along the way. So as you're advocating for yourself, learn about what is going on, learn about the things that seem to be making the connections between what you're experiencing and what you're finding may be something that you're going through, and talk in those terms to try to help connect those dots a little bit better, because I felt in learning more about how to best describe what was going on with me helped me to get to the results I was looking for, and it helped me to get to Dr. Alley's office and ultimately find a solution that was able to help me.
Dr. Alley, that must feel amazing to see patients like Sherry who have such relief. What do you want to say to Sherry?
I couldn't be more thrilled. I'm so excited that she took her own care into her own hands and found us. That's why we went through the trouble of setting up the clinic and putting the information out there, is so that she can live her life. People like her can live their life, without pain. We are constantly striving here to find solutions to multiple different medical problems, but I just couldn't be happier. The durability of the treatment is, as you've just heard, is worth it. So, yeah. Dr.
Thors?
This is a very satisfying condition to take care of. I couldn't have said it any better than Sherry said it. For us providers, this is a fairly simple solution, and for a relatively benign condition for us, but we're not living with this pain. So if you can offer a simple treatment, safe treatment for something that folks have just been miserable with, or like all of us do, that we brush things off and say, oh, it'll get better, or but at the end of the day, those things take a toll. So we have to take that seriously. And the fact that Sherry was able to find help, we just hope that we can continue to get the word out, do the research, and spread this amongst our medical colleagues, because I do think that there's still a disparity of understanding of what this condition is and who can be affected.
Sure. Dr. Thors, Dr. Alley, thank you for taking time out of your busy schedules to join us this morning. And Sherry, thank you so much for sharing your journey publicly. You are going to help so many women, and as we've learned, men who might be going through this as well. And thank you to our audience for being with us today. If you'd like to watch or share any one of our previous episodes, you can scan the QR code that's on your screen right now, and it will take you to links of all of our past episodes. Coming up next week on All Things Heart, October is Breast Cancer Awareness Month. You will meet a woman who underwent a mastectomy made even more complicated because she also needs a pacemaker. The solution, giving her the tiniest pacemaker in existence. That's Thursday at 8 a.m.
Coming up tomorrow on the Morning Medical Update. Prostate cancer is common, unfortunately even more common and often deadlier in Black men. I'm Jessica Lovell. On the next Morning Medical Update, meet a patient who learned he didn't need treatment right away and how his team at the University of Kansas Cancer Center helped make the decision on when to get surgery. Friday at 8.